Well, welcome. How is everyone? Welcome to COVID-19, the Orthopaedic Response. This is a production of DOCSF in partnership with UCSF. I'm your host, Shoshana Butler, and we are so thrilled that we are joined by the American Academy of Orthopedic Surgeons as our global convener in bringing together a global audience to really help us address and think about this rapidly unfolding pandemic and all of the interesting challenges that it creates for healthcare, for our patients, for our communities. And in this particular instance, we're going to be focusing on the interesting challenges that it creates for our professionals, our healthcare heroes, the people who are on the daily interaction in helping us to manage those folks, support those folks who have been diagnosed as COVID positive. And I am so grateful to have Shoshana Ungleider here with us. And so Shoshana, I just want to say hello and say have you say hello to the audience. And by way of introduction, you are an internist. You have a focus and a practice in palliative care. And where I fell in love with you is all of your work on the Endwell project as the founder of that, and thinking about this bigger, broader global conversation that we need to have that we're not having on how to reimagine and redesign end-of-life care and end-of-life experience. I don't know that we have ever seen a moment where we're hitting peak end-of-life type of situation, and we are seeing a set of circumstances that is this perfect storm of situations we never imagined, and I don't think that we were necessarily prepared for. You recently wrote a piece that was published in Time magazine about end-of-life decisions in the coronavirus era. Can you go ahead and share with us what your thoughts were about that?
Well, thanks so much for having me. This is I don't think I've ever spoken to a group of surgeons before, so I feel really honored, and I just want to say thank you. Yeah, I mean, absolutely. As we all know, this is an unprecedented time, moment in history, I think for everybody and for sure in medicine. And so I am trying to do what I can as an internist and somebody who's, I guess I consider myself an advocate around serious illness and the end-of-life experience, not just from the healthcare side, but also sort of thinking about it, culturally, the stigma around talking about death and dying, our own mortality, normalizing hard conversations, not only among healthcare professionals with their patients, but society at large, and just how important that is now more than ever. So the Time piece, which, gosh, we were so thrilled. I co-wrote it with a psychiatrist colleague of mine, Jesse Gold from WashU in St. Louis, really talking about the need, the urgency right now for everybody, including healthcare professionals, to be talking about their own wishes related to end of life, to fill out an advance directive, to assign a healthcare proxy in your own life that could speak for you if you can't speak for yourself. We're putting our lives on the line every single day, as we've been called to do, when we've signed up to do as physicians. And so what does that mean? What should that look like? What are the questions that we need to be pondering for ourselves and then sharing with the people that we love? And we talk a little bit about this idea that potentially with limitations in beds in the ICU and ventilators in staff, are we going to need to be rationing care? Something that I can't even fathom doing. I, of course, was never trained in how to think about that from an ethics perspective, and what are the protocols we can put in place if we do in fact have to do that, to take some of the burden off the individual providers and create standardized protocols around it. So happy to dig into any of that with you now, Shauna.
So we've got a pandemic of a deadly virus, and we also have a pandemic of anxiety and fear. And there is the fear, the public, the fear that they're experiencing, institutions having anxiety, our leaders trying to manage that anxiety. And my experience as a clinician, we always think about, let's talk about our patients first. I think in this moment of time, we need to talk about our care professionals first. And you have spent a lot of time. What I so appreciate about what you do is you give a language and a vocabulary to help us have difficult, sensitive, tender conversations. And so, can you, within the work that you're doing, and particularly with the psychiatrists and the folks who are really helping us to manage our emotional well-being, what are some of the things that you're hearing that care professionals are experiencing? I mean, on the levels of, first of all, their personal safety, their families, their colleagues, the people that they're supposed to be taking care of, and then the community. So talk through what those emotions are and what you're hearing.
Yeah, for sure. I think I would first, want to call out the fact that, all of us know, but we don't talk about the fact that medical education, no matter if you trained 40 years ago, 20 years ago, 10 years ago, or even you're just now out of training, that there is an institutional culture around being strong and tough and really suppressing any emotions that would indicate vulnerability. And especially, I have to say, among surgeons, And
Yeah.
so I think that it puts us at a very unique disadvantage right now in a moment in time where everyone is scared. I don't care who you are, how old you are, if you're a man or a woman or something else, you really, everybody is feeling incredibly scared to go to work every day, to be in contact with their families, to see patients. And again, I think we need to call out the fact that this is absolutely unprecedented. We are absolutely, in every respect, completely unprepared for this moment in time. So what do we do about that? I think, I can speak for myself and for my, professional colleagues and friends in medicine. We've been discussing on Twitter, on Facebook, over FaceTime, that we are all so scared, and we put on a brave face every day and go to work. I'm lucky right now in that I'm getting to do telemedicine from home. My colleagues and many of you are having to truly be out there face to face with patients right now. So for me, I think it's incredibly important when I have those feelings of fear and anxiety that well up in funny ways, where I feel like, oh my gosh, am I getting short of breath? Do I have fever right now? I'm checking my pulse to see if somehow I have been, infected, and thinking, could this be COVID right now? And it's actually, at least in my experience, it was anxiety. It was this feeling of fear that I had stuffed down, because I'm a tough doctor and I got to be strong for my family. And so I think, first and foremost, trying to name, some of these feelings, I think, is truly the first step here. And then I think, of course, being that there is so much fear out there, the question right now is how do we channel that fear, that anxiety, maybe some of those feelings of betrayal from the system, and anger, into being productive, and showing up for our patients, which we're being called to do, whether we signed up for it or not, but we're in the situation nonetheless. It's reality. I think that, it's just a very unique moment in time for us as a profession. And it's, again, what we do with those feelings that are really gonna matter right now.
So you've named that it's really important to name it, to say this is happening, and this is a feeling that I've got, that it's legitimate. I listened to an interview earlier today with the former Fed chairman, Hank Paulson, who led us through some terrible economic times. And one of the things that he talked about was, in order to get through it, he said that the people who did the best were those people who stayed busy, who confronted what those fears were. And so what are the action items that you recommend to colleagues, to help? I mean, once you've named it, you've said this is normal. It's not me. I'm not weak.
Mm-hmm.
What are the actions to take to manage the fears?
Mm-hmm. Well, I think also challenging for clinicians is to reach out to our friends, our colleagues, maybe our families, if it makes sense to share how we're feeling. And I think
we do not have a culture where we say, put your hand up and say,
right.
I'm not doing okay.
That's right. No, exactly. Although I would say that right now, that is so critical for us to support one another. Often, clinicians don't feel comfortable taking their work problems home and talking to their families. It's on all of us to build communities of support and networks, because we're all going through this. We're all having these same emotions, whether we're naming them and talking about them or not. I think that is really, really critical. I mean, for me, I have channeled a lot of my fear and anxiety into journaling, into writing. So I want that's how that time piece sort of came out, was I just sat down one Saturday and I'm not a writer. It just poured out of me. And then I called up my friend Jessie, who happens to be a psychiatrist, who's very comfortable talking about her feelings, and said, let's flesh this out a little bit more. And, how can we share this perspective with the world? Because we think it's really important. And so for sure, I understand not everybody's going to sit at home on a Saturday and write something. But I think that can be really effective. And I think, the tools for managing, personal stress and anxiety, whether it's playing music, whether it's trying to spend more quality time with family, whether it's yoga or meditation, exercise. I got to tell you, I'm using my Peloton bike at home now more than ever. I love getting to tune out and watch those instructors kind of yell at me and listen to loud music. It's truly therapeutic right now, given that I can't really leave the house. So it's ideas like that, and really, recognizing that even if it isn't, in your nature necessarily to take a pause from your work as busy surgeons, that the time, right now it's so critical for us to do that, to take these moments for ourselves, even if it's, just a few seconds in between seeing patients, of taking a breath. That you're going to need that to sustain you. We're at mile 1.5 of a 26-mile marathon here. And as you all well know, this is, we're not anywhere near kind of the peak of this. This is going to be months and months and months. And so trying to build things into your day-to-day life that ground you are so critically important right now.
So one of the things that we've talked about over the last couple of days in talking with a range of orthopedic professionals, people who are in the musculoskeletal segment of care, is many of them are small business owners. So in addition to, I've got to take care of patients, I want to keep them safe. What does my clinical practice look like? They're also employers, and they're dealing with the emotional stress of their family, their practice family, their professional family, and having so many people rely on that as their livelihood, as their connection to a broader community. So there's the clinical concerns and the clinical fears, and there's very much the business continuance, being able to, how do we stay in business so that we can support our community, our patients that need us, and the people that we employ. Are there, those are a specific set of concerns and fears and anxieties. Are you hearing from colleagues about this, and what's your conversation with them like?
Yeah, great question. I think, for me, I'm lucky as an internist that, people are continuing to need primary care. I've shifted to telemedicine, to telehealth, which I would imagine some surgeons can do, although, your physical exam of patients is probably a little more important than mine in terms of the more hands-on. Yeah. But in terms of triaging people, I think that can be a really effective way to figure out, does this person, need to see me in clinic, and sort of without having to come face to face to increase infection risk. But absolutely, and even my friends and colleagues who are business owners outside of medicine, of course, are trying to deal with the weight of the current, economic situation. I keep turning back to this idea that, while of course we have to keep the economy going and think about ways that we can, stimulate growth and think about the future, we can't do any of that unless we can get this virus under control and figure out the ways that we can build a public health infrastructure through sharing of data, of testing, of thinking about isolation versus mitigation strategies that we're hearing about. And so, it's really tricky. And again, this is an unprecedented time that clearly I think we will learn a lot from as pandemics will continue to come. I think I keep getting back to this idea that we will get through this. The world's going to look a lot different, and I think we actually are going to be better for it in the end. But it's going to take a lot of creativity in the coming months and probably years to get, especially clinicians who rely on elective procedures to stay afloat. And it just speaks to more of this need to connect with one another and wrap around each other for support right now.
One of the difficult parts of these conversations, and like I said, we're not good at having these conversations. A lot has been shared in the social space, and what's interesting about the social space is that it's not too close. Somebody can put it out there and you're not really too close, but it is about our individual clinicians thinking very clearly about their own advance directives, about what their end of life wishes might be like, making sure that they have their wills and their financial matters in place, thinking about contingency plans. And I don't know of anybody better in helping guide us in those really difficult conversations that nobody wants to look at that. What's the script? How do we get into that?
Well, as you pointed out earlier, the fact of the matter is that when we show up to work, when we're seeing patients face to face, we are putting ourselves at risk. And unfortunately, with minimal PPE right now, and so the concern is absolutely founded that there is a possibility that one could become sick from COVID. We've seen this across the world and potentially die from it. And so, to me, as scary as it is, this conversation about our own mortality is right in front of us, and it behooves all of us to reflect on that, right? And then, and think about what, how should I be preparing in this moment, if not for me, then just for my family and for my colleagues to be ready just in case, right? I'm going to take every precaution to be safe. But in the chance that you do become sick, you need to have somebody who can speak for you if you can't speak for yourself. And if you are somebody that would want to forego, an ICU stay or a ventilator, it's important to make those wishes known now. And there's a number of great resources out there. The Conversation Project is wonderful. It's one that I often turn to. The 5 Wishes is also an advanced care planning document you can find online. But what truly, obviously as clinicians, we know the nuances of the medical realities so that we could talk more directly about that. But when I'm talking to, the public about this, I think this question about what is quality of life? What does that mean for me? Right. What trade-offs am I willing to make or not for a chance to get better? And I think that now more than ever, this is just such a critical conversation to be having. We're learning so much about this virus and how it presents, the pathogenesis in young people and older people day by day, honestly. There's so much we still don't understand about why someone survives. Why does a young person become ill within a matter of hours and then succumb to this? So what are those predictive variables? And, in this very odd situation of uncertainty, maybe the one thing that we have choice over is our own, goals and values around the end of life. And so I do encourage folks to have these hard conversations, first with themselves and then with the people that they love. And then, of course, with our high-risk patients, if you are encountering people of older age, in your practice, and the question about whether to operate or whether they might want a ventilator, I think that it behooves us right now to be thinking about this in terms of outcomes and who is likely to survive an ICU stay right now, and bring those really hard conversations to the forefront with our patients, with our parents, with our grandparents, if they're still alive. This is really critical.
Well, and so let's shift over into that, because we have this moment where we have asked people who are at high risk to shelter in place. They know that they are
Hopefully we've asked everyone to shelter in place at this point.
Yes, I was going to say, we've asked everybody. Thank you for, everybody needs to be sheltering, stay home.
Yeah.
But we've asked those groups of folks who have underlying conditions, are elderly, who are at the greatest risk that what we're seeing. There's another part of that conversation that needs to be extended. The reality of this is that, okay, what are your end of life wishes? What does that end of life care look like? And we need to be better at having that conversation now, fast. We don't have a lot of time to be able to ramp up. And because we've got people coming into the emergency department, or coming into our hospitals, let's put it that way, coming into our care facilities, and this work hasn't been done. And a lot of times we're seeing really young folks, and it's a rapid deterioration. In that instance, and we're going to be calling upon a lot of people, how do you do these conversations at scale, and also in an urgent moment, and also in a moment where the outcome is really unpredictable? Have you, I know that people have been reaching out to you about that. So what are you sharing with them about that?
Yeah, so my friends at an organization that's been around for a long time called Vital Talk have put out an incredible resource. Obviously, it's online, and hopefully we can share it in the comments, but it is the COVID Vital Talk Palliative Care Guide. This is not just for palliative care providers. This is for any doc to broach the conversation in a quick, efficient manner. It essentially gives you a script almost. In a really thoughtful, caring way, right? For any patient to be talking about, I wish this weren't the case, but here's what I'm concerned about as your doctor. Let's talk about if you are unable to breathe for yourself, would you want X? Or it's just it's really a phenomenal resource. They've gone above and beyond and put this out weeks and weeks ago. So I encourage every clinician to just take a quick peek at it. It's not super long. It really, any physician, nurse, social worker can sort of engage quickly with the script that they've put forward. And I think it's so critical that we do that no matter the age of a patient. So for sure, that resource, I think, it comes to, top of mind for me. And then I think, this conversation about the potential for rationing care and what that might look like in your institution. It's pretty wild to think about. It's truly hard to wrap your head around the enormity of that situation.
So Jim Fick posed a question that I was going to go to next, and I'm so glad that he brought this up. He says, isolation is a huge multiplier of fear. So how does one mitigate the isolation and fear while many of the surgeons are less active? I mean, that was one of the things that we talked about, is that as our orthopedic surgeons, and many of our surgeons aren't busy doing a lot of the same, they're less busy than they have been. Mm-hmm. How can they be helpful in managing the isolation, and then also just the additional stress on the rest of their healthcare colleagues?
Yeah, for clinicians who specifically are feeling isolated, either because they're in quarantine or because they're not working right now, it's really tricky for people who are used to being busy and fixing problems and being out there in the world. I mean, this is a very hard time. I think the more that we can rely on routines, so getting up, going to sleep and getting up every day at roughly the same time, refraining from substances, trying to build exercise or movement if you can't leave the house, into your daily routine, and connecting as much as possible with friends, with people you went to college with or you haven't caught up with in a long time, family members who don't live with you. I think that really, stretch yourself to be connecting with, at least one person a day that you haven't talked to in a while, because it's nice to just check in on them too. But the feelings of isolation are real and are very much anxiety producing. And so again, I think naming that is really important.
So one of the things about isolation that I find particularly hard in caring for people,
Mhm.
and particularly in people who are sick, hurting, and afraid, we have lost the ability to experience human touch.
Mm.
Um, have you got any thoughts about a surrogate or some other way that can provide the physical and the emotional comfort? How can we replace physical? Is there anything that can replace the comfort that comes from just holding somebody's hand?
Mm. I guess, I mean, my answer would be no. Unfortunately, I think, the other things that we can do, or we're getting creative with using technology, is what comes to mind. I would love it if folks out there have ideas about this, because I'm constantly, we hear more stories of specifically patients who are very sick and dying in hospitals where they're completely isolated and alone. Maybe have one nurse coming in once a shift. But what are the ways that we can provide comfort for those people, and of course for ourselves? For me, it's been trying to do a whole lot of video chat, no matter how silly my hair looks or how bad the lighting is. It's trying to find some, like you're saying, surrogate for that in-person experience. Yeah.
I was thinking about Yoko Sen, and thinking about that the last thing that we understand is sound.
Mhm.
What are the last sounds? What are the sounds that are of comfort to you? And when people have been asking me about it, what I've been suggesting is, what are those songs that bring you comfort? Is it Amazing Grace? Is it Prince? Is it Let There Be Peace on Earth? Is it the Star Spangled Banners? What are those songs what are those sounds? So I don't know if that's something that's helpful. The other thing that I've been thinking about, the emotional toll. I've read from several nurses, particularly the ICU nurses, that the way we're cohorting patients is that there's an ICU room or a place where people who are COVID positive are there on their own, and they keep the nurse or the team in there.
Mm.
And they are the only emotional connection. And they are there providing the clinical care, but then also the emotional care, and then also being the connection to the family.
Yeah.
And they talk about themselves feeling isolated and also feeling overwhelmed by the responsibility and the enormity and just the gravity of grief,
Yeah.
the way they have to wear that. And when they walk out of a room, just needing to just decompensate. I think that that's probably just fall apart. And I'm thinking that when I've talked with colleagues about this, they feel like they just want to fall into somebody's arms of comfort. And I'm thinking that how do we as a team, we're all in this together. What are the ways that we can be that soft place for somebody to land when they need to fall into an embrace of comfort?
Yeah. Well, I thank you for bringing up this conversation around grief, because I think that it's much bigger than grief for just our loss of health and loss of lives. For sure, of course, it's grief for people who are dying and loved ones that we're losing, but it's also grief for all the changes that we're having to go through. The lives that we were living 3 weeks ago or a month ago are not.
Our lifestyle, our economy, our
Yeah.
social interactions, our church and faith-based organizations, our proms, our graduations.
Absolutely. Grief for the lives that we thought we would be living, in the months ahead. So I think, high level, I think leaning into this grief and letting yourself feel it if you need to, letting yourself cry or scream or stamp your feet or whatever you need, and making space for that, I think is really important. It takes me back to this idea of journaling, if that's your thing, or even seeking professional support, leaning on your friends and your family for emotional support, because I think that grief is all around us. And frankly, grief is all around us all the time. But I think now more than ever, it's just, in our faces, it's palpable. I think for clinicians, I don't want you to forget about the fact that most institutions have palliative care teams. Granted, they're spread very thin right now. And as you know, palliative care is an interdisciplinary specialty that focuses on the relief of suffering for patients and families facing a serious illness. And in this new era of COVID, really, ideally everybody who comes in the hospital who's beyond just, a medicine ward should be receiving a palliative care consult. In reality, that's impossible given that we're already spread very, very thin. But a lot of palliative care providers have taken to telemedicine, even in the hospital, to try to see more patients virtually to provide that comfort and support alongside curative treatment, right? This is not just for people who are at the end of life. This should really be thought of as a modality that can help support the patients, who are on vents and talking with their families on the phone if needed. And more specifically for providers, helping providers cope. These teams have chaplains as a part of them, social workers, people who really are trained in how to think about debriefing difficult scenarios and talking about the weight of all this. And so I would encourage you to look to those resources if you're in an institution that, most do have palliative care as a source of support through this time.
The other group that gets left out oftentimes is no patient comes in as an island. They have a circle of concern and a family around them. And these situations that we're seeing with end of life where oftentimes the person that you love, that you lose, you are socially distanced, physically removed from them. There's not a way for you to gather as a family. That bereavement ritual, we don't have those. I mean, what we're seeing in Italy, where you can't even have a funeral, you can't have those gatherings. What are your thoughts on how we think about bereavement right now and supporting the people who are surviving and struggling? And I think about that from the standpoint of the clinicians that are here. They've got patients that they may be losing. That doesn't mean that they don't have support and that they want to extend to family members who are now isolated, alone, suffering, bereaving. Is there some suggestions that you have for this group?
Yeah, it's really hard. Grief and bereavement are, if they're not already all around you, I suspect they will be, both in your personal life and your professional life. I think, doctors and especially surgeons always want to be able to fix things to provide a solution. And I think when we talk about grief, for our colleagues and our patients and their families, there is not a quick fix for other people's grief, for their sorrow. I think there's no specific way to provide any kind of solution. I think holding space and just being there for people is critical. The grief is going to take whatever timeline it's going to take. And especially now, I posit that we're actually going to have very prolonged episodic grief throughout time, because we aren't being given the chance for families to witness the death of a loved one, which is the start of the grieving process, to keep them from, being in a state of denial that it happened, which often happens psychologically. And then the next step being, they can't possibly have a funeral and gather and put dirt on the body or into the grave and start saying goodbye there. They can't have rituals like a Shiva, but we have in the Jewish tradition or others where you gather afterwards for days and weeks to provide comfort and food. And so all of the things that we, think of that have been created as these wonderful community building coping around grief and bereavement are gone. And that's going to, I think, create a lot of problems around complicated, prolonged grief, around depression. And so I think first, knowing that to be the case, how can we get more creative with solutions? I'm in a group of a bunch of interesting entrepreneurs who are trying to disrupt the grief and the funeral space right now, and think about how can we have virtual funerals, places of connection. How can we look to our mortuaries and places that provide the hands-on service for the body to be doing things differently. If you have a cultural tradition around burial and preparation of the body, how can we get we still can have those happen without putting more people at risk of infection. So it's there's stuff happening there, but it's a tricky space right now.
Well, I was going to say, on the things that I've been doing on a personal level, is that I set aside a time each day to just feel it, to just say, this is just sad. It just hurts. Um, and during that moment, I think about the people that I'm grateful for. I think about the people that I'm concerned about. I mentally go through and say their names. I make sure I go outside to make sure that I've got a connection with nature. I'm working on trying to get more sleep. I think it helps me to just manage the weight of all of it. I reach out to friends. I make sure and tell people I love them without any feeling ashamed, unabashed, to just say, I love you.
You just told me about an hour ago that you love me.
And I do.
Yes.
I love you. I love what you do. I love how you do it and how you show up in the world. And
I love you too.
thank you. And like I said, I am feeling and holding a very special place for people I don't know and I haven't met, but their stories are universal, and the fear is something that we all experience. I think it's like you said, it's really good to name it. And I also have a lot of hope because they're good, smart people who are working really hard on all of this. And so I just wanted to say thank you for your time. Thank you for your writing about this, for giving us a language and a vocabulary, a place to go and talk and how to think about all of this. And I am confident that we are going, like I said, this will be our finest hour and we will do things better than we have in the past because of people who are leading you, like you, who are helping us to think about these things in the right ways and in safe ways. So I am going to close this session off with a great deal of gratitude and admiration. Stay safe, stay connected, and I will see you again.
Thank you.
Thanks.